Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, United Against Colorectal Cancer, presented by Dr. Arun Srivatsa, gastroenterologist with Washington Township Medical Foundation. Dr. Srivatsa completed his undergraduate training at St. Joseph's College in Bangalore, India. He graduated from Bangalore Medical College. He completed his internal medicine residency as well as gastroenterology fellowship at the University of Rochester Medical Center in Rochester, New York. Dr. Srivatsa is board certified in internal medicine and gastroenterology. He is interested in inflammatory bowel disease, colon cancer prevention, pancreatic disorder, and liver and biliary disease. Please welcome Dr. Srivatsa.
Thank you. Hello, I'm Dr. Arun Srivatsa, a gastroenterologist at the Washington Township Medical Foundation. And today I want to tell you a little bit more about colon cancer, how to prevent it, how to treat it, how to screen for it. I have no disclosures. So the outline for today's talk, we'll go through some facts and figures, hopefully without boring you too much. And then we'll go through risk factors, what you can do to reduce your risk factors of getting colon cancer, how the cancer presents, what kind of symptoms you have, and how do we manage this. But more importantly, we'll also talk about screening. How do we prevent this cancer in the first place, and also how to treat this. So let's get into the facts and figures here. So when we look at the entire United States, we estimate that about 800,000 men and about 800,000 women are going to get cancer every year. So that's a pretty steep figure. And if you look at the types of cancers, colon cancer is about 8% of those cancer cases every year. So you can see for men it's prostate cancer, which is the most common, followed by lung cancer. And then for women it's breast cancer, followed by lung cancer. But number 3, which is pretty important, is colon cancer in both sexes. So that was the new cases. So what about deaths? So about 300,000 people are estimated to die on an annual basis. 300,000 men and 300,000, almost 300,000 women. And again, about 8% to 9% of those deaths are from colon cancer. So these are sobering statistics. So for 2024, we estimate about 153,000 cases just of colon cancer, and these are new cases. And we estimate about 50,000 deaths throughout the United States. The good news is death rate has been improving, so there's been a gradual decline in death rates, mainly because we've been screening and catching cancer earlier, or actually catching cancer before it's cancer, so in a precancerous state. We've also improved treatment of cancer. So if you look at this graph, you look at colon cancer, it's kind of there, down there, the green line. So the highest incidence is prostate cancer, and you can see it's kind of fluctuating, but the lung cancer and colon cancer rates have gradually declined among men over the past several decades. And if you look at women, again, breast cancer is very common, it's very important, followed again by lung cancer, and then colon cancer, again, the green line here is going down, which is good news. Again, death rates, so the previous slides were incidence rates, so these are new cases. But then if you look at death rates, these are people dying from this cancer. You can see lung cancer is a big proportion of cancer-related death, and this is among men, followed by prostate, and again, colon is number 3. And there's a similar graph for women, again, showing that colon cancer is number 3, but still an important cause of cancer-related death. So just to summarize, in 2023, we estimated we had about 153 cases of colon cancer. These are new cases. And as a percent, it's about 8% of cancer. And the estimated deaths was about 50,000 deaths again about 8% of all cancer-related deaths, which gives us a survival of about 65%. So 65% of colon cancer patients will survive to the 5-year mark. And this has been an improving statistic. So this, if you look here at the incidence rates as well as death rates, they've been going down. So let's go into California. So if you look at California itself, about 170,000 cases of cancer on an annual basis, and about 13,000 cases of colon cancer. So you don't want to be part of that statistic. These are new cases of colon cancer in California that we estimate. Again, if you look at cancer-related deaths by state, we expect about 57,000 people in California to die of cancer, and out of that, about 5,000 deaths are going to be from colon cancer, and we don't want you to be one of them. All right? Now, there are some important differences among ethnic and other minorities. So, for example, black men have a slightly higher increased incidence, both of new cancer as well as cancer-related death. And there are some important survival differences in terms of race as well, with black populations having a slightly lower survival rate. So that's important if you belong to one of those ethnic minorities, that you pay attention to that and get screened earlier. Now let's go into the lifetime risk of developing cancer. So all cancers, the probability of developing any cancer for men is about 1 in 2. So that means there's a 50% chance of a man developing cancer throughout his lifetime. That's a pretty high risk. And if you look at colon cancer, that's about 1 in 20. So this is the lifetime probability of developing cancer for men. That means if you know 20 men, one of them is going to get colon cancer during their lifetime. What about women? All sites, 1 in 3 probability. And if you look at colon cancer, 1 in 20, roughly. So again, this is a cancer that affects both men and women. Survival rates have been increasing, which is good. So if you look at colon cancer survival rates in women, the survival rates have also increased. So again, to summarize, colon cancer is something that people will survive, but if you look at stage 1, 90% of them will survive to 5 years. But if you look at cases with distant metastases at presentation, only 15% of them will survive. So this tells us that early detection is key. And this is a graph showing age-specific death rates, again showing that the younger you are when the cancer is diagnosed and treated, the better your chances of survival are. So if you let this grow as you get older, your survival rates reduce and your death rate increases. So what about risk factors? Most people think that they have no risk factors, so they should be not at risk for cancer. But actually, when we look at this, the majority of cancers occur in people with 0 risk factors. So that's news to a lot of people. People with a family history of cancer account for about 10% to 30% of cases. And there are some rare genetic syndromes where there are actual genes that cause colon cancer, and these are very, very rare. So the majority, the biggest piece of the pie here is normal people with no prior risk. So what are these risk factors then? So what can we do? So physical activity, or inactivity rather, would be one risk factor. Being overweight, smoking, certain diets like maybe rich in saturated fats are all big risk factors. Lesser risk factors are actually personal history of polyps, increasing age, and certain conditions like inflammatory bowel disease. And a family history of cancer or a personal history of cancer is actually lower down that list. What's also interesting is the size. So if you look at size of precancerous polyps that are removed, if the polyp removed is small, the risk of cancer is low compared to when the polyp size is bigger. So the key being, get screened sooner so we can remove those polyps when they're small, so we have a lesser chance of developing cancer. And the reason for that is there's an adenoma cancer sequence, which means as these mutations accumulate, you have a normal colonic lining that becomes kind of like a polyp and then becomes a polyp. And if we remove it at this stage, it doesn't turn into cancer. But if you leave that in there, it starts accumulating more and more mutations and then starts getting bigger, eventually forms cancer. And then if you leave that cancer in there, it then gets more mutations that cause it to spread to distant organs. So here's a small graph about family risk. So if you have no family member with colon cancer, your risk is about 2%, which is the average population risk. If you have someone with a first-degree relative with cancer, your risk goes up to about 6%. And then for people with more family members, you get a risk about 8%. If your family member is less than age 45, your risk goes up to 10%. If you have two family members that are first-degree relatives, again, your risk goes up, and so on and so forth. So what can we do to reduce this risk? In our diet, if you increase fiber, vegetable and fruit intake, maybe some antioxidant vitamins, calcium and B vitamins, they may reduce your risk. But actually an increased risk is conferred if you follow a high protein diet, or especially with red meat and animal unsaturated fat. High sugar intake and alcohol will also increase that risk. So talking about presentation, so what symptoms does one have when you present with cancer? So most of the time, these cancers lower down present with bleeding or a change in your bowel habit. Cancers higher up can cause pain, and cancers especially on the right side of your colon will mostly present with pain. Although you see that cancers can present with almost any of these symptoms. So if you have stomach pain, bleeding, any change in your bowel habits, think of seeing your doctor just for an evaluation, because it may be a sign of something more dangerous. Where does cancer occur? So this is a graph of the colon, and you can see that cancer can occur literally anywhere, which is why a full colonoscopy is needed to diagnose and prevent colon cancer. But if you go by statistics, about half of them occur in the first 2 feet of the intestine here, starting backwards from the anus. So your colonoscopy is really going to be quite useful in finding more than 50% of these in this region. All right, so what about stages? So this is stage 0, which is what a colon polyp is. It's precancerous, it's sitting right there. Even if there's a spot of cancer in this can be easily removed and prevented. So then we go to stage 1, where the cancer has started invading slightly deeper into the layers, but still can be removed surgically. Stage 2, it's gone further in, and stage 3 is starting to involve some lymph nodes and some blood vessels. Still can be treated surgically with chemotherapy. Stage 4 is when it starts spreading to distant organs, and that's where the survival starts reducing and the treatment gets more complex. So where does it spread to? Normally the cancer is limited to the colon in a large majority of cases, but if it does spread, it goes to these organs, most commonly the liver, the lung, but it can also go to the brain and the bone. So how do we treat cancer? So as we mentioned, stage 1, surgery itself is curative. In stage 2 and 3, you may need some chemotherapy. Stage 4, you're going to need more complicated treatments. The important thing to know, though, is that treatment of cancer has improved drastically over several decades, and now treatment for cancer is so refined that the side effects are very minimal. So in case a family member or relative has cancer, it's no longer a death sentence. So survival rates have improved really well. But what's better than treating cancer is screening. How do we prevent cancer? We prevent cancer by removing the precancerous stage. So that's where the colonoscopy comes in. We can also help by identifying the cancer early and then sending it to the appropriate surgeon or oncologist for treatment. But why don't people get screened? So there's a lot of either ignorance or misconception or embarrassment about getting a colonoscopy, and that's what we're here to talk about today. One thing we do note is when your doctor tells you to get a colonoscopy or get checked for colon cancer, that seems to have the most significant impact. So talk to your doctor about it. See if it's the right test for you. All right, so a colonoscopy is probably not the most fun thing that you're looking forward to, right? We're not having people lining up outside the door to get a colonoscopy. So I know it's embarrassing, but we need to talk about it. It's uncomfortable to talk about. You're probably not going to bring it up at Thanksgiving dinner, right? But maybe you should. Maybe you're not aware of risk factors, right? Or maybe you just don't like seeing doctors, or you're afraid that it might hurt. So we're here to tell you that a colonoscopy doesn't hurt. It's done with a mild anesthetic, so there's no pain during or after. And it's not a man's disease. It affects both men and women equally, almost, like we showed in the previous slides. We also want to mention that if you have no symptoms, that doesn't mean you have zero risk, because the majority of cancers actually occur in people who have no risk and no symptoms. So who should get tested? Pretty much everyone over the age of 45. So this is the American Cancer Society recommendation, and this states that all women and men should begin screening at age 45, and these are average risk or zero risk folks, right? Now there are some people at higher risk, and we'll come to recommendations for them. So how do we screen? How do we screen for cancer? So this is the colonoscopy. It's a thin tube with a camera. It also has some channels where we can use to put some instruments and get those polyps out, right? So it's pretty painless. It's done with anesthesia, and for patients who are sensitive, we have a female nurse and an anesthesiologist present, so you're safe and comfortable during the procedure. And how do we get polyps out? Basically, this is a polyp. It's a growth. It can be precancerous, so we use an instrument called a snare. We lasso it, and then we apply electrosurgical cautery and cut it out, and then we retrieve the specimen and test it. So it's pretty safe. We do about 10 of these every day on a regular day. We do thousands of them. We do about 10,000 of these in a year. All right, so it's pretty safe and well tolerated. What about cost? So talk to your doctor again about this, and talk to your staff, the medical staff in the office. They'll be able to tell you if it's covered. Typically, screening is usually covered with no out-of-pocket expense for people starting age 45, and usually it's covered every 10 years. You may have a copay or co-insurance or a deductible, especially if you're younger than age 45 and you want a colonoscopy, or if you're getting it more frequently than recommended. If biopsies are taken or polyps removed, you may get a bill from the lab. So let's talk a little bit more about screening. So everyone should start at age 45, but what happens if you have a family history? We'd start either at age 40 or 10 years younger than the youngest family member. And then if you have certain genetic mutations, we'd start really early, but again, talk to your doctor or oncologist and they'll be able to tell you about these. So are people getting tested? So quite embarrassingly, less than 50% of people are actually getting age-appropriate testing. So because of that, only 39% of these cancers are being detected early. And like I showed you on a previous graph, early detection means survival rates are much better. Again, there are some ethnic and racial differences, and in terms of sampling healthcare and access to healthcare. So if you belong to one of these minorities, pay more attention to your risk because you might be a higher risk. So why aren't people getting tested? Again, many barriers might exist. Most importantly, either it's ignorance or a misconception or embarrassment. But talk to your doctor about it and get advice, because the best recommendation for you to get screened can come from your doctor. So what happens if you don't want a colonoscopy? So there are many other options. If you don't want a colonoscopy, that's okay. There are other tests, so ask about these tests. So you can do a stool test. A stool test could be a simple guaiac test, which is very commonly available, and it tests for the presence of blood in the stool. And you can get that annually. There are certain advanced stool tests like a fecal immunochemical test and a DNA test. You can do these less frequently because they're more sensitive and they detect not just blood, but they can detect tumor DNA and other mutations. What happens if a stool test is positive? You're going to still need a colonoscopy. So it kind of circles back to getting that colonoscopy, but at least you're getting tested with a stool test, right? So if the stool test is negative, maybe it may reassure you and your doctor. So don't worry about getting which test, one versus the other. The best test is the one that gets done. So make sure you get at least something in terms of testing for your colon cancer risk. Now, the guac test can be false positive based on certain items in your diet that can activate peroxidase. Certain sushi items, or if you eat meat that's slightly raw or tender, you might be getting a false positive test. It could also be false negative, which means it's normal while you have a polyp that's precancerous. And this could happen if the polyp didn't bleed on that day, or the amount of blood was too small to be detected. It could also be that the sample wasn't fresh. So there are other options. There are some blood tests that can actually detect tumor DNA circulating in your blood. And these are some names of companies that offer these tests. You may have to pay out of pocket because not many of these are FDA approved, but these are also a surrogate for detecting these abnormal cells. And if these are positive, you should definitely get a colonoscopy. There's also some news about virtual colonoscopies. This has been around for a few years, where you'd get a CT scan instead of actual colonoscopy, and the CT regenerates certain images. This is not widely endorsed because Medicare doesn't pay for this anymore. It has a high radiation risk, and if there's something seen on this, you still need a colonoscopy, so Medicare just stopped paying for this. There's a pill camera that can produce some images, again looking for polyps. And again, if this comes into practice, it's not clinically available yet, but if it does come into practice, you're still going to need that colonoscopy to get that polyp out. So why do we talk so much about getting your colonoscopy? It's because of this. So if the cancer is detected at later stages, the survival rate steadily declines, and it's in single digits if cancer has spread widely. But if the cancer is detected early, you have more than a 90% survival at 5 years, which is pretty good. So what can we do? What can we do to reduce our cancer risk? So follow your testing guidelines, especially starting at age 45. Ask your family members if anyone had colon cancer. Get your exercise, don't smoke, or don't drink heavily. And you can also reduce your risk by eating enough fruits and vegetables, whole grains, and limiting red meat intake, and maintaining a healthy body weight. All right? But the most important thing you can do is talk to your doctor about getting screened, and also to encourage your friends and family. If you've been screened and you've had a great experience and it was a walk in the park for you, tell your family, tell your friends, tell your neighbors. All right? So take-home messages. Colon cancer is reducing in incidence. Death rates are improving, mainly because we're catching it earlier and we've improved treatment. But eating right, keeping a good body weight and healthy lifestyle will reduce your risk. Screening for colon cancer will reduce your risk. And most people will get screened only when their doctor tells them to, so ask your doctor if screening is right for you. And if someone has colon cancer, it's not as big a deal as it used to be because treatment has improved, and so now death rates and survival have all improved vastly over the past few decades. All right, I'll open it up for questions, if any.
Thank you, Dr. Srivatsa. We do have some questions. The first question we have is, you talked about all different ways to be tested for colon cancer. What is the number one best way to be tested or screened for colon cancer?
Yeah, that's an excellent question. So I would say the best screening test is the one that gets done. So if you don't want a colonoscopy, it's okay to ask for something else, and your doctor will recommend a stool test usually, or maybe a blood test, or maybe a CT scan. But if you ask me, and I'm probably biased, I'm going to say a colonoscopy is the best technique, because not only can you detect precancerous polyps, you can remove them at the same time, so we can prevent colon cancer in a very sophisticated and safe fashion.
Okay, thank you. Our next question is, you talked about blood in the stool. Is blood in the stool always obvious? What would it look like?
Again, an excellent question. So blood in the stool, if it is obvious, like if it's bright red and it's present when you wipe on the toilet paper, usually that's from a hemorrhoid or something really low down. Usually doesn't indicate something as dangerous as colon cancer, because colon cancer, the bleeding can be very subtle in the early stages and you may not even see it in the stool. So that's why it's important to get your stool tested when your doctor asks you to, because it may look normal but actually might be hiding traces of blood. And on the other hand, when you see frank bleeding in stool, most often it's just a hemorrhoid. But then, better to get tested. So ask your doctor about any symptoms you have, such as blood in your stool, and ask them what the next best step is.
Okay, and our last question is, what is the recovery time from a colonoscopy, and is it done in an inpatient or outpatient setting?
Sure. A colonoscopy is usually done in outpatient setting. So you come in the morning and you're back home by lunchtime. The procedure only takes about 20 minutes, maybe 30 minutes, and you're fully asleep during that with a mild anesthetic. As I said, there's a nurse and an anesthesiologist that make sure you're safe. So you usually just need that day off, maybe even just the half day off, but we recommend you don't drive for the rest of the day and don't do anything strenuous. But really it's not a big impediment to your daily lifestyle. So you just need to make time, and you need to make the effort to get it done.
Okay, thank you. This concludes our program. Thank you, Dr. Srivatsa, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.